Start, ma'am.
Okay. Good evening, everyone. This is Dr. Veena Venkatesh, working at Ajanta Pharma Limited as General Manager, Medical Services. On the behalf of Ajanta Pharma, I welcome all the delegates for today's scientific program. Ajanta Pharma is one of the fastest growing pharmaceutical companies with a research orientation. It's known for bringing innovative first time in India formulations. We thank our doctors for their continuous support with us, with our brands. Today's topic would be advances in hypertension. Has the ideal CCB arrived? I take this opportunity to welcome our distinguished faculty members. Dr. Michael Weber from New York, Dr. C. Venkatram, Dr. Mrinal Kanti Das, Dr. Abhijit Tarfadar, Dr. Muruganathan, and Dr. Uday Jadhav. It's my privilege to introduce Dr. Mrinal Kanti Das as chairperson for today's program. He is MD DM with the fellowships FICP, FICC, FCSI, and FACC. He is a consultant and interventional cardiologist at BK Birla Hospital, Kolkata. He is President CSI, Governor ACC India Chapter, Editor-in-Chief of Cardiology, Update 2019, Joint Editor of CSI Textbook of Cardiology, published over 70 articles in national and international journals. With the brief introduction of Sir, I would like to hand over the session to Dr. M.K. Das. Sir, you please take over the sessions. And the request for our delegates, please put your questions in the chat box and it will be addressed once the talk is over. Sir, over to you, sir. Sir, your audio is mute. Kaustubh.
Good evening, everyone. We are going to have a very storming session on hypertension, especially in relation to the calcium channel blockers, which is coming newly in the horizon. And we have got a galaxy of stalwarts today evening in the form of Dr. Michael Weber, then Dr. Ram, Dr. Muruganathan, then Dr. Uday Jadhav, and also Dr. Abhijit Tarfadar. I'll introduce all of them in course of time, but just to start the proceeding, I would like to highlight that this is a very important issue, that which drug should be chosen for taking care of hypertension, because of the fact that there are so many drugs which can be chosen for particular issue. But our main issue is to reduce the cardiac mortality as well as the morbidity. And that can be reduced if we take care of the blood pressure in the most effective way, considering many facets, whether it is the diurnal changes or circadian rhythm, or even the other facets like the pleiotropic effect, vasodilation, then also the hypertrophy, various kinds of heart failure, especially in the form of the diastolic heart failure. All these will be discussed. But today we have got a very eminent speaker, Dr. Michael Weber, who is the professor of medicine at Downstate College of Medicine of the State of University of New York. He is amongst us. He has actually many aspects in relation to the hypertension management. Especially, he has been associated with important drug therapies and also the device therapy, 24-hour ambulatory monitoring, and he has been the president of the American Society of Hypertension, American Society of Clinical Specialist Accreditation Program, and he is also the editor-in-chief of the Journal of Clinical Hypertension. So let us present to you Professor Weber. Professor Weber, please.
Well, thank you very much, Dr. Das, and let me say what a pleasure and honor it is for me to join so many colleagues in India this evening and to be part of what I'm sure is going to be a very interesting program. My job is just to make a few introductory comments. Since I've been around for many years, I do recall when calcium channel blockers were first introduced, now more than 30 years ago. And it's really quite remarkable when you think about it, that here in 2020, we're all gathered together to hear about yet another important breakthrough, another important development in the history of the calcium channel blockers. It's actually been quite a wonderful story. And those of you who've been practicing as long as I have, it's probably only a few of you, I'm afraid, I can recall very well the early calcium channel blockers, drugs like verapamil and diltiazem. They were not the dihydropyridines that are so popular now, but they're still used because they are very effective in angina, and they're also quite effective for slowing the heart rate and for situations like atrial fibrillation where you need some rate control. Those older calcium channel blockers, the non-dihydropyridine calcium channel blockers, are still quite valuable. And I know quite a few cardiology friends who still like to use diltiazem for treating angina. But it's the dihydropyridines that basically have dominated the field of hypertension. And I think quite rightly so, because they have shown themselves to be very effective in controlling blood pressure. They've shown themselves to be very effective at cardiovascular and renal protection. What I like about the dihydropyridines is that they are universal drugs. So if you have a mixed patient population, you know that your calcium channel blocker is going to work just as well in old people as in young people, just as well in black people as in white people. They work well in South Asia. They work wherever you want to use them and in any population that needs to be treated for hypertension. With all of that said, what I really like too is that they combine so well with other drugs. We know that dihydropyridines, whether it's long-acting forms of nifedipine or now probably the more popular amlodipine, you can combine those drugs with beta blockers, you can combine those drugs with diuretics, and of course, best of all, you can combine them with ACE inhibitors or angiotensin receptor blockers, where they are very effective in controlling blood pressure. In fact, there are a lot of very good fixed combinations now with the dihydropyridines. And I was fortunate enough over the years to be part of clinical trials like ALLHAND, where it was expected that the long-acting diuretic chlorthalidone would be the best drug for preventing events in hypertension. Guess what? It was amlodipine that turned out to be most effective at preventing mortality. I recall the ASCOT trial, where in combination with an ACE inhibitor, it was far superior in preventing major events to the more traditional beta blocker diuretic combination. I recall the VALUE trial, where amlodipine was remarkably effective at preventing stroke and myocardial infarction. CAMELOT, a study in milder hypertension, where again, very good major outcomes benefits. So I could sit back and say, we don't need to do any more, except that there are some problems. Much as I love long-acting dihydropyridines, they are not completely effective. They at times can cause edema. For many patients, that is quite a serious problem. And they can also cause other issues, such as increases in heart rate. Not everyone feels comfortable with the calcium channel blockers. So it's amazing that we've reached a point where we're now looking at a brand new calcium channel blocker. And I'm not going to talk about it. Dr. Venkata Ram is going to give us a presentation, and he's really very, very knowledgeable about this important new discovery. But some of the problems that we've encountered, some of the side effects of earlier drugs now appear to be very well dealt with. And there's more than that. Very good evidence for beneficial effects on the heart, on kidney function, and other important endpoints for people who are worried about patients with hypertension. So this is for me, a very exciting moment, because I'm looking forward to hearing Dr. Ram explain more about azonedipine and telling us how perhaps we can look to the future with therapy that is even a step further ahead than what we currently have. So let me stop now, and I look forward to talking again a little later with my colleagues. Dr. Das?
Thank you, Dr. Weber, for your beautiful introduction on the subject. We really, your works on this particular aspect, especially the CCBs and other therapeutic aspects on hypertension, are remarkable in nature. In fact, all of us are following those. Now, I am presenting to all of you Professor C. Venkata S. Ram. He's the director of Apollo Institute for Blood Pressure Management and Apollo Blood Pressure Clinics. And he's also associated with the Department of Medicine, and he's professor there in the Apollo Medical College. He's also the director, Texas Blood Pressure Institute and Clinical Research and Medical Education, DNA, clinical professor of internal medicine, University of Texas, and also vice president of American Society of Hypertension Specialist Program. In fact, I have a really good relationship with Dr. Ram, which is spanning for last 7 or 8 years. And so far I know that he's not only a very, very good gentleman, but he's a thorough research worker who has been associated with the works of Professor Norman Kaplan. And in fact, I saw one obituary by him, written by him, in fact, that was showing his heart in the whole aspect of hypertension being put into the obituary. And that's a great one. Hats off to you, sir. And really, I don't have to tell about you in front of the gathering, especially who are listening in India. And now I am putting the whole session to you. You just highlight us about the new CCB and what's their implications, what are the trials and studies and all these things. Over to Professor Ram.
Okay. Thank you very much, MK. Greetings to all of you. We will spend some time on learning about the pharmacological aspects of therapeutic advances. But at the outset, we must all concede that the ultimate beneficiary of whatever we do today or tomorrow should be the patients that we're going to see on Monday. So any clinician who discusses a therapy for any disorder has to be absolutely certain that the real beneficiary will be the patients and their families and the community health. So that is the basic fundamental principle of therapeutic advances. And one more thing that I want to comment, I hear this quite often whenever there is a new drug, not necessarily for hypertension, but for diabetes or for arthritis or for asthma. Sometimes people say, why new drugs? But new drugs are generally developed on the foundation of the older drugs. So whenever we have older drugs for any disorder, there is no condemnation of the older drugs because they are the ones which show the pathway for future advances. So whenever we see newer developments in either device therapy or pharmacological therapy, we're only building on what has been available before, and we offer our respect, but not a condemnation. Similarly to the computers that we're using now, we had in the beginning when I started, like most of us, we had 286, we had 386, we had 486, we had Pentium. But when we are using Pentium, we are not disrespecting the earlier versions, 386, 286, 486. Same thing with the printers that we have next to your computer. We used to have dot matrix printers. Now we have laser, we have improved laser, but we use what is more efficient. Similarly, in terms of pharmacology of drugs, the pharmacological technology has enabled the molecules to be more efficient and more helpful, but without any disrespect to the earlier predecessors of the molecule. So when we talk about newer developments, we talk about just like computer technology, we talked about pharmacological technology, how it has advanced, and that is what I wanted to share. Now let me talk about a few general comments, and then we'll talk about the new molecule. This is a slide that is the title of the thing, because as Dr. Michael Weber has narrated the historical chronicle of calcium blocking drugs with verapamil, diltiazem, dihydropyridine, there has always been a quest for, is there an ideal CCB, like an ideal husband, ideal wife, ideal father, ideal mother, ideal teacher? We also want to look for an ideal calcium blocking drug, and then I'm going to talk about it. How do we, is there some way to advance? I'm not able to advance this one. Okay, it has advanced. Now, the reason why CME programs of this, especially when it is done by people who have a lot of experience, it saves you a lot of time. You don't have to go to, I don't think not many people go to the library anymore. Look at the number of publications that appear every year in general, and nobody can keep up with these things. I can't keep up. So the programs of this nature are quite helpful. Now, cardiovascular disease in India, if we don't control it as of today, if we just leave it the way it is, I don't think we should, you will see the incidence of hypertension will approach very soon almost 215 million people. So that is due combination of so many countries where everybody has hypertension. So ladies and gentlemen, it is very important to control hypertension as effectively as possible at this moment. Otherwise, you're going to see a geometrical increase in the number of people who qualify for the diagnosis of hypertension. This is something that all of you have seen before, but it is very important to know that the principal driver that ignites cardiovascular disease in India is hypertension. So anybody who has got cardiovascular disease, there is overwhelming chance that it is provoked and augmented by history of hypertension. And these are the data then from India, that uncontrolled hypertension is responsible for a large number of deaths from stroke and large number of cardiovascular disease. And now the financial impact is tremendous. I'm not talking about just for hypertension, I'm talking about cardiovascular disease, myocardial infarction, heart failure, CKD, end-stage renal disease, renal transplantation, heart transplantation. It comes to almost $10 billion a year. So ladies and gentlemen, $10 billion US per year to take care of people who have complications from hypertension. So definitely prevention is better than the cure, where the old adage, you see this, no country of any economy can support that kind of an expenditure on healthcare costs to take care of people who have complications of hypertension. Oh, by the way, I want to mention one thing. This comes in health economics all the time. The cost of medications for any disorder are only 10% of the healthcare costs. 90% of the costs are for the complications and hospital care. So do you want to have 10% or do you want to have 90%? And the choice is yours. There used to be an old expression in US, Michael Weber will remember, which used to say pay now or pay later. It is better to pay now 10% than to pay later 90%. And this is a wonderful article that I want all the viewers to please read it if possible. It is a compilation of 142 articles published from Evidence in India and by Dr. Achala, Public Health Foundation of India. 1/10 of rural and 1/5 of urban population, only 1/10 of rural and 1/5 blood pressure is under control. That means majority of them have a diagnosis of hypertension that has changed. They go to doctors, they go to hospitals, but the diagnosis doesn't change, they still have hypertension. Now, there was some debate a few years ago when the American guidelines were published about the levels of blood pressure to qualify as hypertension. And the controversy is almost over. But now let's look at our own country. What happens if the systolic blood pressure is between 120 to 129? There is a 16% increase in death rate. Now, if you take the blood pressure 130 to 139, previously called pre-hypertension, the death rate increases by 19%. So ladies and gentlemen, blood pressure is a hemodynamic abnormality. It doesn't matter where you live. It does not matter where you live. When the blood pressure starts going up, it can cause significant cardiovascular damage. This is a study that we just completed. It is in press in a major journal. We looked at 530 patients presented with acute stroke in the Apollo system. Clinical stroke confirmed by CT and MRI, you will see that majority of patients had history of hypertension. So, ladies and gentlemen, you have for the first time a prospective study in India showing that hypertension is a leading cause of acute stroke in our population. One of the things that is very common in India is diabetes. Now, if you combine diabetes with previously called pre-hypertension or mild hypertension, you combine diabetes with mild hypertension, they have the highest mortality. So ladies and gentlemen, forget about pre-hypertension. Please call that as stage 1 hypertension. And this is a nice compilation. It's possible Dr. Weber might have reviewed this article for the Journal of American Society of Hypertension, where it was mentioned that majority of cardiovascular events occur in people with blood pressure less than 140/90. So ladies and gentlemen, don't wait for 180/110. Don't wait for 220/130. Please, that is aberration. Majority of the complications occur under 140/90, which is the need for the new classification. Now you will release that, you will know that the European guidelines have identified South Asians, namely Indians, as a high-risk category. So if you are Indian by birth, you have a 40% increase of cardiovascular risk at the same level of blood pressure as your counterpart. So one risk factor from hypertension is not only the level of blood pressure, but your origin. We have that origin genetics that automatically puts you at a higher risk. Now, what about American College of Cardiology, American Heart Association? Last year, ladies and gentlemen, for the first time, they have identified that the risk is higher in Asians. By Asians, they don't mean Japanese, they don't mean Koreans, they don't mean people from Thailand or Philippines. Trust me, they mean people from South Asia. Trust me, from South Asia means Indians. So Indians have high risk of cardiovascular disease, even at modest levels of blood pressure. Now, the question always comes up, the methodology of taking blood pressure, however you take it, even if you reduce it a little bit, you have an enormous benefit. So this modest reduction in blood pressure can cause significant reduction in annual cardiovascular morbidity and mortality. Now, this is a summary slide that probably many of you are seeing for the first time. I have put the definition of hypertension according to European Society of Cardiology. I have put the hypertension definition according to American College of Cardiology. And I have put the definition of hypertension according to International Society of Hypertension from last month. You will see that 3 definitions change slightly. But what is important, very important, that is why it is in the green color. All of them suggest a goal blood pressure of 130/80 or less. So ladies and gentlemen, don't panic about which guidelines you want to follow. Don't lose your sleep on which guidelines you want to follow. Follow any guidelines you want, but the goal of all the guidelines is to achieve a blood pressure of 130/80. Now the arguments will start, it is not easy, it is not easy. Nobody is saying it is easy. If it is easy, it would not be part of guidelines. So ladies and gentlemen, forget about the debate, which guidelines you want to follow. Any guidelines you want to follow, it's up to you, but all of them have a commonality of the goal blood pressure of 130/80. One thing that we always forget talking about hypertension, we talk about heart failure, we talk about kidney disease, we talk about stroke, but we always forget to talk about dementia. One of the most important complications of hypertension in the elderly is dementia. And this is a study from CISTUR where the dementia score or cognitive function improved substantially after the treatment of hypertension. So ladies and gentlemen, you should persuade your patients to control their blood pressure, to keep their mental health. They may not listen to you about heart or kidney, but at least they will listen to you that the risk of dementia is significantly decreased when you lower the blood pressure to the goal levels.
So Dr. Ram,
Now,
Dr. Ram, just 1 minute. Could you put the slides in the slideshow mode? Because many people are saying that the size of the slide is actually small.
okay, all right.
That's fine. That's fine, sir. Thank you, sir.
Now, we talk about pharmacological treatment of hypertension, but pharmacological treatment of hypertension always comes as a complementary or conjoined to non-pharmacological treatment. Salt reduction reduces the blood pressure, and regular exercise, not occasional exercise, weekend exercise. I hear this all the time in Hyderabad, India, that they go to the gym on Saturday and Sunday. Going to the gym is only a small part, but the problem is regular aerobic exercise has been shown to reduce the blood pressure, and of course the weight loss has been shown to reduce the blood pressure. Now, one should not wait for months and years to normalize the blood pressure. One should try to achieve the goal blood pressure within 3 to 6 months, and I'm going to talk about Dr. Weber's analysis of the VALUE trial. This is from CISTUR, that if you reduce the blood pressure quickly, within 3 months, you reduce complications significantly. So please try to reduce the blood pressure as quickly as possible. Don't wait for too long. This is the analysis that Weber did, very elegant analysis, and widely quoted in the medical literature, and a high impact factor for this particular study, where he has demonstrated that those people whose blood pressure is normalized quickly, within few months, within 6 months, they had a better survival in terms of mortality and freedom from morbidity compared to those whose blood pressure is normalized later on. So ladies and gentlemen, don't wait for some august movement to appear. Once you see the patient, try to normalize the blood pressure within few weeks, because you normalize the blood pressure quickly, you reduce the duration of hypertension. If you take too long, you are prolonging the duration of hypertension. you want to shrink the duration of hypertension, and you want to prolong the duration of normotension. And that's very, very simple. Now, the only reason why we treat hypertension today with drug treatment is because of this trial shown on the slide called Veterans Administration Cooperative Trial, which was done in late 60s and early 70s. First trial to show that if you give drug treatment for hypertension, the patients will live. If you don't give drug treatment, the patients will have cardiovascular events. You will notice in that orange color are the patients who were treated for hypertension with drug treatment, and the amber or white color are patients who did not receive the treatment. And the differences are obvious. And this is a monumental study for the first time demonstrating in our lifetime that those in whom you reduce the blood pressure with drug treatment, their cardiovascular event rate is survival is much better than where you ignore the patient. In fact, this is the only reason why we give drug treatment for hypertension. Now, let me come to the second segment of my discussion, which is this evening's topic. All of you are familiar with all the pharmacological classes of the drugs that are on the slide. But due to the scope of this meeting, I want to concentrate on calcium channel blocking drugs. But other drugs that are mentioned there on the slide, they are very useful either as monotherapy or in combination with combination therapy. But let us focus like a classroom that today's class is going to be on calcium channel blocking drugs, but we always have to consider other drugs as well in clinical practice. Now, all the guidelines, including the last month's International Society of Hypertension guidelines, they always suggest initiate treatment with combination therapy, not as monotherapy. Now, when you look at antihypertensive drugs, blood pressure control is the goal, but I do believe that along with blood pressure control, one should look at the effects on the heart, one should look at effects on the kidney, one should look at effects on the brain, on circulation. So the holistic pharmacology of antihypertensive drug therapy is a physical phenomenon, namely blood pressure. But a pathophysical phenomenon is reflected by heart, kidney, brain, and circulation. All of them might be related to blood pressure. But the pharmacological effects of the drugs could have an impact on cardiac function, kidney function, brain function, and circulation, which we'll discuss now. Now, calcium channel blocking drugs, as Dr. Weber has pointed out, they have become cornerstone of antihypertensive therapy because as he clearly pointed out that they are broad spectrum antihypertensive drugs. They are age independent, they are gender independent, and they are race independent. So you really don't need to know too much about the patient other than the blood pressure. In fact, if you're not seeing the patient, you don't even have to know what is his gender, what is their color, what is their age. You can close your eyes and prescribe a calcium channel blocking drug, the blood pressure goes down. So that is the reason why this has been always termed as broad spectrum antihypertensive drug, where you really don't have to, I don't want to use the word too smart. In US, they use the word no-brainer. It's a no-brainer. Somebody has high blood pressure, you give calcium blocking drug. The importance of calcium in vasoconstriction was discovered in 1883 by Sidney Ringer, that our surgeons use Ringer's fluid in the operating room. And then subsequently it was developed by Japanese co-workers. As Dr. Weber has pointed out, the first generation of calcium blocking drugs were mainly so-called cardiocentric, not blood pressure centric, but cardiocentric, namely verapamil and diltiazem. Their effects on blood pressure were there, but they were not that dramatic until the introduction of nifedipine. After nifedipine, number of calcium blocking drugs were developed in so many years. From 1964 until now, we have actually a plethora of calcium blocking drugs, culminating in the current availability of ezellonidipine. Now, what is an ideal dihydropyridine CCP? It should be as effective as amlodipine because amlodipine is a gold standard for blood pressure reduction. It should be broad spectrum, it should be tolerable, should synchronize with combinations, it should not have side effects like ankle edema or tachycardia, and it should have effects on kidney and the heart that have not been shown with amlodipine. Now, when people talk about calcium blocking drugs, sometimes we forget you're thinking about the bone, you're thinking about parathyroid hormone, you're thinking about calcium levels. No, nothing. Calcium blocking drugs do not interfere with calcium metabolism other than the calcium effect at the vascular smooth muscle. At the vascular smooth muscle, interaction between actin and myosin causes vasoconstriction. And this interaction, actin and myosin, is presided, governed by calcium. If you give a calcium blocking drug, any calcium blocking drug, it prevents the interaction between actin and myosin. It separates them. It is like two wrestlers. I don't know if you see some boxing and wrestling matches. When it goes out of hand, the referee comes and separates them so that there is no volatility. Similarly, a calcium blocking drug removes the volatility between actin and myosin so that there is reversal of vasoconstriction and promotion of vasodilation. Ladies and gentlemen, the field of dihydropyridine calcium channel blocking drugs is one of the most thoroughly investigated fields that I know of. I think this is a partial list of dihydropyridine calcium blocking drugs, sorry to say. This is a partial list, and because these molecules are so important that there has been a lot of developments, but we'll concentrate today on just one or two molecules. These are the generations of calcium blocking drugs that have been developed over the last few years. The relatively short acting is nifedipine. Somewhat longer acting is amlodipine. Somewhat longer acting is cilnidipine. And much more longer acting is azilnidipine. So if you look at generations of calcium blocking drug in terms of biochemical pharmacology, it allowed the drugs to have a longer duration of action. Nothing wrong with the older drugs, nothing wrong at all. But the newer generation has a longer duration of action and slow onset, and that is the reason why you have blood pressure control without so-called reflexive side effects. One of the calcium blocking drugs, which is third generation, is cilnidipine, which blocks the L channel like amlodipine, but it also blocks the N channel in any neurogenic channel. So L channel is vasodilating, N channel is sympathetic blocking drug, and cilnidipine has both L and N. That is the reason why it lowers the blood pressure, but it also lowers the heart rate. And this is what you see the difference between cilnidipine and amlodipine. With cilnidipine, there is a reduction in heart rate. With amlodipine, there is no change in the heart rate. Sometimes it goes up. Effects on the blood pressure are the same. But the pharmacology of cilnidipine is such that it blocks the N channel, namely the sympathetic blocker, and lowers the heart rate. Blood pressure effects are the same as amlodipine. Now, let's concentrate on this. It's really not a new molecule. It's new for India. It's more than 20 years of development in Japan. And I have known some of the investigators. In fact, in preparation for this symposium or webinar, I got in touch with many of them, and I have secured and assembled the information that I have culled from the research. Azilnidipine is mainly a L channel blocker. L stands for long acting. Like amlodipine, it's a vasodilator. But it also has a little bit, not much, a little bit of T channel. But because it is a slow release acting and long duration, it has got a smooth effect on blood pressure and does not cause tachycardia like amlodipine. So azilnidipine is like amlodipine for blood pressure, but because of its pharmacology and binding to the membrane, it does not elicit reflex tachycardia. And it is effective, and it is highly lipid soluble. And because of high lipid solubility, it does not cause reflex tachycardia. In the earlier studies, you look at the earlier studies, 2003, they have shown that ezellonidipine, a very preliminary trial, in fact does reduce a BP. So one pharmacological principle has been satisfied, that it is an anti-hypertensive drug, causes so-called double-digit reductions in blood pressure. Then naturally, it has to be compared to the gold standard of calcium blockers, namely amlodipine. And if you look at the comparison between ezellonidipine and amlodipine, a crossover trial, again from Japan, and this investigator sent me some data, you will notice efficacy is the same. You can't tell the difference. So one important thing is ezellonidipine is as effective as amlodipine for blood pressure. And this is one more study, a little bit more recent one. I wanted to put a more recent one, again showing that ezellonidipine and amlodipine efficacy is very similar. And they also compared with another calcium blocking drug used in Cysture called nitrendipine. So it has been similar efficacy. So in terms of the efficacy, ezellonidipine is as effective as gold standard amlodipine or its predecessors, nitrendipine and nifedipine. One difference appears to be that ezellonidipine has a modest reduction in the heart rate. It is because of its gradual onset and smooth duration of action. It does not reflex tachycardia. It is not whipping the heart. It is sedating the heart. It is not whipping the heart. If you use a short-acting nifedipine, it is whipping the heart. But you see ezellonidipine is actually had so-called sedative effect on the heart, reduction of the heart rate. So ladies and gentlemen, and Mr. Chairman, in the heart, ezellonidipine is acting like a beta blocker in the heart. Now, what about combination therapy? Because that is the new mantra of drug therapy. And this is a slide looking at the effects of adding ezellonidipine to previous therapy. You will notice in people who are on multiple drugs before, when you add ezellonidipine, it lowers the blood pressure. So it is an important component of combination therapy. We always talk about diurnal variation in blood pressure, 24-hour blood pressure control. One of the things that we know, chronobiology, and I spoke to Dr. Cass Cario, who is the principal investigator of the study, the morning rise in blood pressure is often associated with increased risk of cardiovascular complications, whatever the reason. It could be blood pressure, it could be coagulation, it could be endothelial damage, doesn't matter. But here, in the study that was done by Cass Cario, he looked at the morning to evening blood pressure, the sum. You will notice it was significantly reduced with ezellonidipine, suggesting that it attenuated the morning rise in blood pressure. It aborted the morning rise in blood pressure. Why is that important? And this is a study again from Japan, again from Cario. Those people who had a morning rise in blood pressure, not in this study, but in another study, had a higher risk of cardiovascular complications. So, ladies and gentlemen, it is very important to prevent the morning rise in blood pressure, to prevent early morning rise causing stroke and transient ischemia attacks. This is something that I had written as a concept long time back. Sorry to say that I'm revealing my age. That what is the mechanism by which calcium blocking drugs might actually reduce atherosclerosis, not due to blood pressure, but due to calcium blockade. And this was confirmed in studies with ezellonidipine. You will notice, looking at intima media thickness as a surrogate marker of atherosclerosis, the long-term use of ezellonidipine has shown a significant reduction in the intima media thickness, whereas with amlodipine, there was no change in intima media thickness. I would think the changes in intima media thickness are due to atherosclerosis. So what we thought long time ago, 25 years later, looks like some calcium blocking drugs do have so-called anti-atherosclerotic effects, maybe related to blood pressure and maybe not. I can't tell. Now let us look at the cardiovascular effects. This is an experimental study in a spontaneously hypertensive rat looking at regression of left ventricular hypertrophy and regression of aortic atherosclerosis. You will notice calcium blocking drugs have a significant effect on regression of LVH as similar to ARBs, no different. This is an interesting study. I know Dr. Uday Jadhav and our chairman are very prominent cardiologists in the country, and they look patients with heart failure, they look patients with diastolic heart failure, they look at BNP as a marker. And this is a study in patients receiving azonadipine and looking at BNP. You will notice there is a fall in BP and there is reduction in BNP. Is it due to fall in BP? I can't tell. But one thing is there is a reduction in B natriuretic peptide suggesting an improvement in cardiac function. This is very similar to the previous study. Now we have added C-reactive protein. And now you look at C-reactive protein, that also goes down. So it looks like on vascular function, it has effects on cardiac function and also on inflammation. And sympathetic nervous system, which is stimulated by amlodipine because it's a good drug, but it causes the blood pressure to go down quickly. There is activation of sympathetic nervous system with amlodipine, but with azonadipine, there is no activation. Actually, there's a deceleration of sympathetic nervous system. So it looks like in some aspects, it is imitating a beta blocker. We always worry about cerebral blood flow when you treat hypertension in the elderly. We are always worried that you reduce the cerebral blood flow. And my former mentor, late Dr. Kaplan, asked me to do this study. What happens to the cerebral blood flow when you reduce the blood pressure gradually and not suddenly? So we did this study, not many patients, where we showed that if you reduce the blood pressure gradually, the cerebral blood flow does not go down at all. So you don't have to worry. So ladies and gentlemen, when you treat hypertension in the elderly, when you reduce the blood pressure gradually, the way all of us do, don't worry about cerebral blood flow because it is auto-regulated. And this has been what has been demonstrated with azonadipine. In elderly patients receiving azonadipine, the blood pressure came down, but cerebral blood flow was maintained because it is auto-regulated. So the conclusion that one can infer, you drop the blood pressure, but you don't drop the cerebral blood flow because it is auto-regulated. So that is a good comfort zone for people treating hypertension, especially in the elderly. Now, Abhijit is our national expert, or actually international expert on nephrology, physiology, and pathophysiology. One of the things that has been shown with amlodipine and nifedipine in the earlier years is that in patients with diabetes, it can provoke proteinuria because it causes dilation of afferent arteriole, not efferent arteriole, increases intraglomerular pressure. So in diabetics, when you give amlodipine and nifedipine as monotherapy, there is some chance of aggravating proteinuria, not in combination, but as monotherapy, because you increase the intraglomerular pressure by dilating afferent, but not efferent. But azonadipine and the new generation calcium blocking drugs, they dilate both afferent and efferent arterioles. So there is no accumulation of intraglomerular pressure. Because there is no increase in intraglomerular pressure, actually the proteinuria goes down. So ladies and gentlemen, very interesting, in the kidney, azonadipine is acting like a ROS blocker. In the kidney, remember I told you in the heart, it is acting like a beta blocker. In the kidney, it is acting like a ROS blocker because of reducing proteinuria. And this is a study in diabetic hypertensives looking at proteinuria with amlodipine. It did come down a little bit, but there was substantial reduction with azolnadipine has an antiproteinuric effect. This is another study which looked at crossover, where patients receiving azolnadipine had a reduction in protein excretion, whereas with amlodipine, there is a paradoxical increase as monotherapy. So it's very interesting that on the blood pressure, azolnadipine is acting like amlodipine, but in the kidney, it is acting like a RAS blocker. Now, I'm coming almost to the end. What about diabetic hypertensives, which is very important population in South Asia? And this is a study that was looking at insulin resistance with glucose infusion. You will notice in patients receiving azolnadipine, the insulin sensitivity was maintained, whereas amlodipine, the insulin sensitivity is lost and they have developed insulin resistance. So here it is acting as a cardiometabolic drug of some nature, where in comparison with amlodipine, it appears to have a salutary effect on glucose metabolism. And I do not know what the mechanism would be. Effects on the blood pressure were very similar. Amlodipine increased the heart rate, but the effects on glucose tolerance were quite different between these two drugs. Now, I will skip this aldosterone trial. I talked about, remember I showed you one diagram where we should look at effects on circulation. One of the important parameters for circulation for thrombosis coagulation is pi1. And this is a small study that looked at the pi1 levels with azolnadipine. There is a reduction in pi1 levels. So ladies and gentlemen, in circulation, it is acting like a modest anticoagulant. Blood pressure acting like amlodipine, heart acting like a beta blocker, kidney acting like a RAS blocker, and circulation, it is acting like a slight anticoagulation. And inflammation, cardiology, acute, and both of you, both Chairman and Uday Yadav, they deal with inflammation. It appears to have an anti-inflammatory effect as reflected by CRP. How important it is, how necessary it is, how essential it is, I can't tell, but these are only surrogate parameters. Abhijit sees a lot of patients with chronic kidney disease and with renal vasoconstriction as one of the phenomenon. This is in animal models where vasoconstriction was deliberately induced. And when you cause renal vasoconstriction, there is a decrease in renal blood flow. But when they added azolnadipine, the renal blood flow was restored. So it looks like it may have an anti-ischemic effect on the kidney, probably through its microvascular effects. So ladies and gentlemen, I have drawn a full circle. Then I'm coming back now to the beginning. The end is going to join the beginning. So an ideal dihydropyridine CCB should be as effective as amlodipine. I think from the data we have seen that the azolnadipine is as effective as amlodipine. I have shown you the data mainly from Japan on the efficacy. It appears to be quite effective. It is well tolerated because of reduced incidence of ankle edema. And I showed you the study with combination therapy. It is less likely to cause proteinuria. I will never say it doesn't. Is less likely to cause ankle edema. By the way, ankle edema and proteinuria, they have same biophysical mechanisms, proximal and distal. Ankle is nothing but a glomerulus. What happens in the kidney happens in the ankle. Always ankle edema, proteinuria go together. So based upon published literature, there are almost 300 publications. I read 50 or 60. Azolnadipine appears to provide some freedom from so-called classical DHP side effects, namely ankle edema, tachycardia, proteinuria. and it appears to have effects on the kidney and the heart that I have shown you. Now, ladies and gentlemen, based upon the VALUE trial, and the principal investigator is with us, Dr. Weber, how to prevent progression of hypertension. You must always start early. When you see a patient with hypertension, that is the best time to treat hypertension. There is no future ideal time. When you see somebody's blood pressure is high, that is when you start treatment. Whatever treatment you start, doesn't matter. Because you have to, so-called, and I'm using the word in the COVID era, you have to flatten the curve. You have to flatten the curve. And you're flattening the curve by the early diagnosis and early treatment, because the longer you wait, the prevalence will increase. Because, by the way, waiting doesn't help the patient at all. Hypertension begets hypertension. It is just like somebody with fever. Waiting doesn't help at all. They keep on increasing the fever from whatever the reason. So, Mr. Chairman, ladies and gentlemen, in the time that was allotted to me, I covered few aspects of antihypertensive therapy, the focus on calcium blocking drugs and new generation, and some of the pharmacological aspects, biochemical pharmacology, pharmacological technology, etc. And I have culled the evidence that is published, and I have put together. Most of it is clinical, 1 or 2 experimental slides I have shown. Hypertension, diabetes, tobacco consumption, male gender, obesity, they are risk factors. They're not disease. Being a male is not a disease at all. When you have risk factors only, the blood vessel is healthy, as it is shown here. It has got a nice lumen, it has got no atherosclerosis. So when you see a patient with hypertension, who has no disease, the blood vessel is healthy, the way it is shown here. Nice, with normal blood flow, no atherosclerosis. But when patients with hypertension develop hypertensive vascular disease, their artery lumen is obliterated by atherosclerosis. So what was a healthy blood vessel has now become unhealthy, and this is called hypertensive disease. If you don't do anything about hypertensive disease, they develop an event, acute MI, acute stroke, malignant hypertension, and progression to end-stage kidney disease, where there is complete vascular disease as shown on the slide. So we start with a patient with hypertension who is healthy hypertension, and the blood vessels are healthy. But when you don't do anything about it, the person, by the way, somebody who has got high blood pressure is not a patient, is a person. But once you develop vascular disease, you develop hypertension becomes a disease with vascular component. When you don't do anything about hypertensive disease, they become disabled as a result of acute MI, acute stroke, malignant hypertension, kidney failure. So it goes through these risk factors where the patient looks very benign, very healthy, happy. But if you don't intervene, the happiness goes down and the patient develop LVH, proteinuria, creatinine 1.8, 1.9, little bit of intima media thickness, occasional TIA, occasional loss of memory, little bit of proteinuria. That is hypertensive disease. And if you don't do anything about it, they come for dialysis, they come for organ transplantation, they come for stroke management, and some of them, unfortunately, will not even survive. So this is the sequence from risk factor to disease to events, and you have to interrupt and intercept at risk factor. You have to stop the train before it goes on the track. Because if it goes on the track, it is going to reach the next station. And the next station could be kidney failure, heart failure. So ladies and gentlemen, please stop the train on the track of hypertension. That's when it starts. So in the beginning, ladies and gentlemen, after Michael Weber's introduction of the theme, I talked about hypertension in India, its current status, its economic impact, its prevalence, and the importance of aggressive blood pressure control in India. Namely, I have written an editorial, all the new guidelines appear to be directed towards India, although they don't say it, for aggressive blood pressure control. India is the ultimate beneficiary of aggressive blood pressure control. Then we talk about the importance of non-pharmacological treatment and the pharmacological options we have. And due to the scope of this meeting, we have narrowed it down to CCBs and recent advances. And I've showed you the pharmacology, clinical effects, and where we started, I closed the loop. Ultimately, we have to do what is right for the patient at the right time so that you prevent wrong complications. Mr. Chairman, ladies and gentlemen, I'll conclude with those remarks. Thank you very much for your attention.
Thank you, Professor Ram, for your erudite speech. In fact, while talking about the flattening of the COVID scenario, you have actually flattened all the audience by your extraordinary classroom teaching on calcium channel blockers, as well as the hypertension in total perspective. In fact, I thought that I'll be summarizing some of the points, but since we are having less time, so in the interest of the time, I'll be straight away going for some of the questions that have been put by many audiences across the table. And to actually answer some of the questions, along with Professor Weber and Professor Ram, we have got three more stalwarts. One is Professor A. Muruganathan. He was the past president of API and Hypertension Society of India, and is presently the governor of the American College of Physicians India chapter. He is a BC Roy awardee, and he's really a champion of hypertension in India and across the globe. And second one is Professor Abhijit Tarafdar, and who was a WHO fellow. He also was the professor in the IPGEMIA, the premier institute of the postgraduate institute in Kolkata. And right now he's the professor and head of the department of nephrology in Apollo Hospital. And lastly, we have got Professor Uday Jadhav. He's attached to MGM University of Health Services, Health Sciences, Mumbai. And he has actually been instrument for many research works in the field of hypertension, dyslipidemia, imaging, and rhythm disorders. And he has been fellows of different colleges and societies. And without much talking about their achievement further, I'll straight away go to the questions. First question I'm putting to Dr. Ram himself. Are CC blockers compatible with other antihypertensive drugs? Are CC blockers?
First, I will comment on it, but you have a galaxy of faculty that you have cited, and they will also participate. I think calcium channel blocking drugs, usually when you look at that hexagonal that you people show with combinations, there is no contraindication with other drugs at all. Only verapamil diltiazem you try to avoid in patients who are on beta blocker. With dihydropyridines, there is no limitations with combining with other classes of drugs.
Thank you, Dr. Ram. Now,
In fact, may I add, apart from antihypertensive drugs, certain antifungal drugs, especially acetylcholine, will have it's contraindicated, and also the HIV protease inhibitor atazanavir, if you give along with the acetylcholine, it's contraindicated. And when you use with the digoxin, azithromycin, and erythromycin, when you give this drug, you should be very careful.
Yeah, thank you, Dr. Muruganathan. Actually, I was asking about the antihypertensive drug interaction, but you have already highlighted the interaction with other kinds of non-hypertensive drugs. Now, next question I'm going to Dr. Uday Jadhav, please. Any role of or contraindication for this as azilnidipine in heart failure?
I don't think we have a very large data numerically to say that this is a drug that will make an impact in terms of a add-on therapy in heart failure. But it has a certain small advantage. One is its lowering of the heart rate because of the blocking of the T-wave channels. So acting on the late phase of the depolarization, phase 4. I think that's important. And secondly, though this has not really been in the heart failure segment, but there was a small comparative study between azilnidipine and benedipine. And they looked at both the parasympathetic activity, the sympathetic activity, the burst frequency. And in that aspect, the sympathetic response got lowered down. So maybe if you're hypertensive with a heart failure and is in a requirement of a calcium channel blocker, azilnidipine, being a LNT channel blocker and with its effect on lowering the heart rate could be an add-on advantage. Besides what Professor Dr. Venkatram highlighted about the reduction in the PNP level. So yes, that's a sort of add-on advantage. That's how I would put it.
In fact, reduction in the B-type natriuretic peptide can be beneficial in improving prognosis at heart failure patients.
In fact, since it has got multiple other actions, especially in reduction of the left ventricular hypertrophy and all, so it has got some role in the diastolic heart function as well, though the size of the trials that have been carried out with azilnidipine is not robust, but still possibly it may have some action. So now going over to Dr. Tarafdar, please. Now, the nephrologists have got a sort of fascination for using more of cilnidipine versus the amlodipine. Now, would you like to switch over from cilnidipine to azilnidipine because it has got more beneficial effect in terms of acting on the T channels and thereby influencing the aldosterone mechanism and also decreasing the glomerular pressure? So what's your take on this?
When a nephrologist selects an antihypertensive agent, there are a few aspects he keeps in mind. Firstly, there should be good round-the-clock blood pressure control. Second, these patients, the patients who are hypertensive, should not have masked hypertension or will not show rising blood pressure at night. Third, as has been highlighted, there will be proteinuria reduction or quote-unquote renal protection. And fourth, there should not be any adverse side effect, as for example, ARBs or ACIs in advanced renal failure may cause hyperkalemia. So keeping in mind all these four aspects, we have to consider any agent, be it azilnidipine or cilnidipine or anything. Now I come to the question that you have raised. What about comparative study between cilnidipine, amlodipine, and azilnidipine? Coming to blood pressure control, is as good as amlodipine 5 milligram. So that is one, that blood pressure control is good provided you are using 16 milligram of. So this is one. Second issue is renal protection. Renal protection, proteinuria reduction, it is said that all the agents like cilnidipine, benedipine, so-called, those are which are acting on calcium channel, namely TN, they are also reducing proteinuria. But the question, bigger question is whether proteinuria reduction can be translated into renal protection. And there are big questions whether proteinuria reduction is synonymous with renal protection. If you go by GFR reduction or maintenance of GFR, or if you wish to make the slope relatively slow, in that case, I don't think there is any hard data to show that there is any significant difference between these agents. Rather, there was one publication in Drugs recently where 5 calcium channel blockers were studied head to head for 1 year. And it was found that after 1 year, there is no significant change in GFR preservation in terms of all these 5 calcium channel blockers. So if you go by proteinuria reduction, yes, but how much it is translated into renal benefit, that is one question. Second is regarding GFR preservation, there is only one study as I know, and there has not been any significant difference in 5 leading calcium channel blockers. Third issue is where I think that this agent has something to, from a nephrology standpoint, it is said that they have a beneficial effect in terms of aldosterone, beneficial effect in terms of uric acid. Both are said to, as for example, aldosterone is said to cause aggravate renal fibrosis. So its good effect on aldosterone may reduce renal fibrosis. Uric acid, by the work of Rick Johnson, it is said that possibly it also increases intraglomerular pressure. So if it reduces uric acid, then once again, it is renoprotective. But the other thing that I'm interested in is these agents, they also has anti-sympathetic effect. And this anti-sympathetic effect is different from cilnidipine. Cilnidipine acts on N-type receptor. So in diabetic nephropathy, when you have diabetic neuropathy, this beneficial effect of cilnidipine on N-type receptors is gone because of advanced diabetic neuropathy. But these agents, which act through D-type receptors, possibly they have an effect centrally at the rostral ventrolateral medulla, where by its antioxidant effect, it tends to reduce sympathetic drive. Now we are more interested in afferent sympathetics from the kidneys. So if it reduces or controls sympathetic drive, even in patients who have advanced diabetic neuropathy, then it has an edge over cilnidipine. However, once again, I reiterate that there is no head-to-head study between azilnidipine, benedipine, amlodipine, and cilnidipine so far as a long-term preservation of GFR is concerned. So there is only one study I know of where only 1 year study was done where GFR was compared between 5 calcium channel blockers, and there is no significant benefit that could be accrued with any of the calcium channel blockers.
Yeah, could you come back to the original question, whether you are going to switch over the from cilnidipine to azilnidipine or not?
Switch over, I mean, whenever any new calcium channel blocker comes, mechanistically, this is a LT type calcium channel blocker. And
no, I want a straightforward answer actually.
No, the question is, when there is any new calcium channel blocker, we try it. We put our hand on it, we try to use it and try to see how much good is blood pressure control, how much is protein.
Okay, thank you, Dr. Tarafdar. I'll go straight away to Dr. Muruganathan. Dr. Muruganathan, would you highlight the use of azilnidipine as a first-line drug in Indians? Because we, the Indian physicians and cardiologists, they are very fond of using the amlodipine as a first line of drug, vis-a-vis the nephrologists who use more of cilnidipine. Now, would you recommend the azilnidipine as the first-line drug?
I must confess, I don't have much experience in azilnidipine, but the way it has used in Japan for the last 20 years, and we see the papers, it's very impressive. And Dr. Venkateswaran has clearly said and very simplified, on the heart, it acts as a beta blocker. On the kidney, it acts as a RAS blocker. It has got modest anticoagulant. It is also anti-inflammatory, antioxidant, and also it has aldosterone reduction effect and hyposuric effect. So combine all these actions, I think it falls into category of a good drug. So, but time alone will tell us how the future will be, because it's all in the paper. Now you start using, we may come across certain problems. It reduces the heart rate, edema is reduced, and all the overall the 17 times more lipid profile, lipophilic compared to amlodipine. So all these things in the paper looks like is better than amlodipine. And the study with the amlodipine and the olmesartan, the reduction was very smooth in the azilipine. So when you see all those data, I'm tempted to use azilipine, but not immediately, because we'll have to wait and watch the Indian scenario, and then only we can start using it.
Yeah, thank you for your highlighting the whole topic in a different way. Okay, now my next question is to again you, Dr. Muruganathan. Now it has been shown that it is really going to help in insulin sensitivity management. Now, will you be comfortable with the drug in diabetes mellitus with hypertension?
Yeah, we have seen the studies in various comparison study where it preserves the initial insulin signaling with the glucose uptake. So in a diabetic hypertension, the main problem is insulin signaling and the glucose uptake. So when you see all that, it becomes one of the a drug for diabetic hypertension. And as I said, the more and more we use, we'll know better. Now we are using amlodipine, and once we know, we are more comfortable with, because the heart rate is also reduced, and then it has got additional effects. So maybe on paper, it looks better than amlodipine, and we can use this because of the insulin signaling and also in the glucose uptake mechanism.
Yeah, thank you very much. Dr. Uday, could you say something about the central aortic pressure, which is a very, very important factor in reducing various kind of cardiac morbidity and also mortality? So how far azilnidipine actually helps in central aortic blood pressure management?
Right. So there is a small data on the augmentation index and the central aortic pressure and the pulse pressure with azilnidipine. Again, I'm saying numerically this data is not very large, but it's beneficial. Central aortic pressure will become important in terms of reducing the morbidity and mortality in elderly hypertensives. We don't have a guideline as of now which says that therapy should be based on the central aortic pressure. It's a component of how you look at patients and how you're going to treat them in clinical practice. So yes, azilnidipine will be useful because it's specifically to azilnidipine. The concept is great. It will work for elderly, but it's not a guideline-based therapy as of now. Thank you.
Thank you. I'll go to Dr. Tarafdar again. Now, suppose the creatinine, this question has been put by one of the audience. Suppose the creatinine is increasing. So in that case, whether azilnidipine can be continued on.
If you go by the studies, there is only one study which was published in NDT in 2013, where azilnidipine was used with a creatinine up to 2 milligram in males and 1.5 milligram in females. So their recommendation was it can be given in moderate renal insufficiency. There is no data as of now, but if you go by the mechanism and the other calcium channel blockers as well, we are prescribing other calcium channel blockers like cilnidipine and benidipine at a creatinine even at a higher level. So there is no harm in writing azilnidipine. We should write it. The only thing is that we have to follow up these patients, see if the renal function deteriorates and serum potassium level is how much. But as we have already said, as it has anti-aldosterone effect, so maybe that the potassium will not go up, and there may be some beneficial effect on renal function also. But for that, we have to have our own data, and that is one of the requests to the company, that we should have a study of our own. In India, we should have our pooled data, our own study, own assessment, and then we'll be able to say whether azilnidipine can be used in a relatively advanced renal dysfunction.
Yeah, thank you. We must go for the post-marketing the trial and all. So PMT is very, very important. We have not really used, I don't know whether Dr. Ram has used azanidipine to a great extent or not. But I have got two questions to Dr. Ram actually. One is, when should we use the azanidipine as a monotherapy? This is number one, monotherapy of azanidipine with the azanidipine. So number one, and number two, can it be used in cerebral hemorrhage?
I'd like others also to comment. Now, if you look at the guidelines, the hierarchy of initial choice of therapy has been completely dismantled. So there is no hierarchy among the major classes of drugs, which I have put as primary agents in the slide. So calcium channel blocking drugs can be used as initial therapy according to all the guidelines. So there's no hierarchy. So certainly for patients who have hypertension requiring drug treatment, calcium channel blocking drug into the azanidipine, and the dosage that I think that Abhijit mentioned, which is very, very important, by the way. I didn't talk too much about the dosages. I was only looking at the pharmacological profile, not dose response. Like 16 milligram, it appears to be a pretty good dose for the initial treatment of hypertension. But some is monotherapy, but is it almost like a combination therapy because of its effects on sympathetic nervous system and effects on the kidney, effects on the heart, and is it acting like a actually multiple drug therapy? We do not know, but yeah, sure, it can be used as a initial therapy for hypertension according to the guidelines. Is dihydropyridine, sure.
Thank you. So there is no much of difference between all the calcium channel blockers. They are mostly showing the non-inferior sort of effect. Right. And the value trial definitely has shown in favor of amlodipine in preventing the cerebrovascular accident or reducing the morbidity and mortality. But one question that has been put.
Also, one more before that, Venkatram sir, you said 16 milligram. For elderly patients, they say you have to give only 8 milligram. What is your take on that?
I mean, this is an important question that comes up all the time on the elderly. Despite whatever guidelines people give, it really doesn't matter when you are seeing an elderly patient. You do what is right for the patient, which is sometimes not in line with guidelines at all. If you want to give a low dose, if you're going to give half a dose, because first we want the elderlies can tolerate it, no problem at all. Actually, I wanted to ask if at the conclusion of the last answer, because Dr. Weber analyzed that Ascot trial quite effectively, and then there are also age groups in that value trial also. Along with age group, it really did not matter as long as it's reduced the blood pressure a little bit early, not wait for too long. Michael, you want to comment on your as an investigator of the trial, value trial, and also other trials that you have done?
Well, thank you, Venkata. I mean, certainly, as you pointed out, people over a certain age, whether it was 65 or 70, seem to have the same benefits, the same protection from fatal and non-fatal cardiovascular outcomes as younger people. But the trial that I think has influenced the treatment of the elderly more than any, well, there are two in a way, the HIVET study done in people over the age of 80 in Britain and parts of Europe, and now more recently the data from the SPRINT trial, where in the cohort of patients aged 75 or older, when they were treated aggressively and had their blood pressures reduced to less than 120 or as close to 120 systolic as possible, they not only tolerated it, they had enormous reductions in mortality. And no drug works better in older people than a calcium channel blocker. Well tolerated. So I think you've opened the door, Venkata, to getting much more aggressive in older people and making sure that we do the right job in protecting them from major events. We can do it, and and it's already been shown by others that when you treat older people, not only do they seem to tolerate it well, even when they're frail and old, there also does not seem to be any negative effect on cognitive function, on dementia. In fact, a trend in a good direction, suggesting that we're helping with mental processes. So very much a strong message. Let's treat old people very well and if necessary, quite aggressively.
One question has been put by the audience. It's to Dr. Michael, actually. Any genomic impact on clinical practice with azilnidipine? This is number one. And number two, whether this drug is FDA approved or not. Genomic impact on clinical practice with azilnidipine.
Well, very little genomic impact on clinical practices yet. We just don't have enough data. And I'll be quite candid with you. I've read some of the work with this new calcium channel blocker, azilnidipine. Some of the work that Venkata presented earlier, impressive. It is not FDA approved yet, and I don't know, quite frankly, whether that work is in progress. Practicing here in the States, I very much hope it is, because Venkata persuaded me that this is going to be a drug that's going to solve a lot of problems for our patients. It's going to be very attractive in people who've got ongoing heart disease, very attractive in people where there's some question about renal function, very attractive in people with diabetes. I hope that we'll see azilnidipine here in the States, but as is becoming the case now, India is going to lead the way, and here in the States, we're going to have to learn to follow. Venkata, I really enjoyed your presentation. A lot of very valuable information there.
Yes.
One question from me is that the calcium channel blocker is useful in vasoreactive pulmonary hypertension. Is there any study on azilnidipine for pulmonary hypertension? Michael?
I don't know.
Venkata, did you have knowledge about that?
Aware. Uday or anybody has looked? I am not aware of it because pulmonary hypertension, unfortunately,
not in primary pulmonary hypertension, not in PPH, not in primary pulmonary hypertension.
No, not in PPH, right.
If I may, I know it's overshooting time, but because I'll get an opportunity to learn from Venkat and Michael both. One observation that leads to this question, though the data is small in most of the trials, the at-home trial has a lot of patients, 4,800 patients. I noticed one thing, that the heart rate reduced in such a large number of patients on an average of about 3.54. And when you analyze the daytime and the nighttime change in the heart rate with azilnidipine, in the nighttime it went down by 2. Is this important with blood pressure lowering medication? When you talk of nocturnal dip being maintained, or a good nocturnal blood pressure reduction with BP lowering medicine, is it important also to preserve the heart rate? Is it something that could be really beneficial to these patients who have hypertension? So that's a sort of query I had, in mind. Please.
Dr. Ram, could you hear? Or Dr. Weber also can.
I'm sorry, I had a technical difficulty there for a second. Uday, could you just repeat the last part of your question?
Yeah, Michael, so here is the question. This at-home study about 4,800 patients, and what was seen is that the heart rate on an average reduced by about 4, the heart rate reduced by 2 in the night hours when they looked at a 24 hours ambulatory blood pressure. So is this important when a patient is on blood pressure lowering medication to preserve his heart rate in the night hours, just like we look at nocturnal dipping of the blood pressure? Is it good to have a heart rate also preserved in the night hours? Does that benefit patients with hypertension?
That's a great question, Uday. And there doesn't seem to be much of an answer to that. We do know that people who have high heart rates at night respond very well to sympathetic and calcium channel blocker kind of types of therapy. There's more and more interest now in heart rate as a simple index of sympathetic activity, so that somebody whose blood pressure remains high and also has a tendency to a higher heart rate, particularly at night, may be a particularly good target for aggressive therapy. Normally, we want the heart rate to fall at night, don't we? Because that's part of the reduction in sympathetic activity that goes along with our circadian pattern. And we see the increase in heart rate about 4 or 5 o'clock in the morning as part of the arousal process, even before people start waking up. It seems to be the initiator of the whole waking up and arousing process. But at night, I would assume that the low heart rate is a good thing to achieve.
Thank you, Michael.
Dr. Ram,
And
should we wrap up?
now one more question before you wrap up. The azanilipine is known to restore baroreceptor sensitivity, thereby BP variability and tachycardia are done. So is there any study between amlodipine and azanilipine in the BP variability?
Actually, I did not show it. There is actually one paper, I suspect that you have studied it, that's why you're asking, is the baroreceptor resetting appears to occur with azanilipine than amlodipine. But why does this happen? We do not know. Is it a fluke? We do not know. Can it be reproduced? We do not know. Can it be applied to community at large? We do not know.
Yeah, every good thing has to end. Actually, we had a very, very beautiful session, very much educative session throughout last 1.5 hours. And Dr. Ram, who is a great orator, Dr. Michael, who actually highlighted the basis of the calcium channel blockers and their efficacy in terms of reduction of the cardiac mortality and morbidity, and all the other panelists, they have done extremely good job in highlighting many aspects of the hypertension vis-a-vis the hypertension mediated organ damage, as well as their implication. And also Dr. Ram has elaborately gave us a sort of classroom teaching regarding the overall scenario of calcium channel blocker vis-a-vis the azanilipine, which is a sort of new drug in the horizon. And for any new drug, we have to wait for some time till the post-marketing studies come out, and our own experiences are actually gathered, and definitely we will be going for it. And in course of time, definitely we'll be telling much more about the azanilipine rather than what is being talked today. So with these few words, we are concluding the session, but before that, I will put the mic back to Dr. Veena and other organizers to give their comments as well as the concluding remarks.
Yes, sir. Thank you very much, sir. It was indeed a very interesting panel discussion so far. All of us, we really enjoyed it a lot. And we thank, on the behalf of Ajanta, Dr. M.K. Das for an excellent moderator of the session. And I take this opportunity to thank Dr. Michael Weber for bringing us the historical aspects of CCBs, and of course, Professor Dr. Venkat Ram for an extraordinary talk and then highlighting the salient features of the azanilipine. We also thank Dr. Abhijit Tarafdar and Dr. Uday Jadhav, Dr. Muruganathan for giving an insight into the cardiologist's perspective, nephrologist's perspective of the CCBs and especially the azanilipine. So thank you very much. It was indeed a very interesting and very educative session we enjoyed. And we extend our thanks to all the delegates who were part of this session, and then throwing up a lot of very interesting questions, and it was a learning session as well. We also thank our head office team and the field force and the technical team for making this program a very success. And I thank one and all. Thank you all.
Thank you.
Thank you.
Thanks, Michael. Thank you.
Thank you very much, and have a good evening. And